My name is Dr. Tyler Tolbert,
And I'm Dr. Soren Poppy,
and you're listening to the Fix Podcast.
your source for all things implant dentistry.
All right, and welcome back to the Fix Podcast. Just to update you guys, I guess it was maybe the weekend before last, the weekend before that, everything blurs together. But I attended the first annual ORCA Symposium in Las Vegas, which had a really, really impressive lineup of speakers. And one of them is here with us today, Dr. Sven Bone. He got up on stage and there were so many different lecturers there that came from a variety of backgrounds and spoke to so many different things. And it was really an incredible conference. I really enjoyed it. But Dr. Bone got up there. First of all, coolest name in dentistry. I'm just going to go ahead and put that out there.
Right on.
And he got into some really, really interesting concepts. We're going to get into them today, including, Dr. Bone is bringing a whole lot of experience from a background in physics that we'll talk about. He has his own lab. He's a prosthodontist. He also does surgery. He does full arch, all these wonderful things that we talk about. And I got to talking with him after the symposium about some of the things we spoke about. And we got into some really cool topics that I just thought would be amazing for the show. And he's been gracious enough to come on. So Dr. Sven, thank you so much for coming on.
Of course. Yeah, it's a pleasure to be here. And I do have one correction. I actually don't do surgeries anymore.
Oh, okay. Well,
yeah,
you've done them.
Yeah,
you're aware of the concepts.
Yeah, my implant experience is I've placed I probably around 100 or so not a ton.
Oh, okay.
And basically I really dove into the manufacturing, the design, and really kind of stuck with the pros side of things.
Got it.
So
got it. Yeah, sure.
Yeah.
Well, I think that's all the better. And really when, we argue that when people go about learning the pros first and then kind of working your way backward is really the appropriate way to do it. Because the difference between just being able to say you did this and doing this well really goes down to those types of fundamentals. So I'm really, really happy to have you on here. And I know you can go deep on that kind of stuff.
Yeah, totally. I think, and if we look in the literature, the number, if you just look at complications, you're going to see them. They're all a lot of them are orbiting around the pros side of things.
Oh, totally. Of course.
On complication rates. So I think a solid foundation in this is really critical. Surgery is sexy, right? Surgery is, and all the surgeons will admit to that. But the pros side, sometimes that's where things can get really kind of challenging.
Yeah. And if you're not doing the pros side correctly, then you'll be doing a whole lot more surgery, but probably not the kind that you want to be doing. So
possibly. Yeah, absolutely.
That's right. So before we get into brass tacks and everything, for those that are unacquainted with you, could you just kind of give us a walkthrough of your whole academic journey into what's kind of fed into all that? I know we don't have to go too deep. But let's kind of canvas.
Yeah, I started out. So I left home. I grew up in Western North Carolina as a kid, and I left home when I was 18, and I moved out to Montana, and so I studied. I knew I wanted to study physics as an undergraduate, and so I did. And in that time, I physics majors have to get minors in mathematics in order to get a degree, and so I was I ended up at the time, a big revolution was happening in biology, and I became really interested in kind of the biology side. So I took a few biology classes, and one of my lab partners was going to be a dentist, and so. Because I asked him, I was like, "What are you going to do, John?" And he goes, "I'm going to be a dentist." And so I'd never thought of that before, never once. And I started looking into it, and then I realized, like, wow, dentistry is a beautiful combination of medicine, it's art, and engineering, really.
Mechanics, of course.
And so I was like, wow, this could be a really good avenue for me. So I ended up taking more pre-med type classes and decided to go on and finish a degree in mathematics. And so I have two undergraduate degrees. One's in physics, the other one's in mathematics, with more of applied side. So basically, it's trying to solve real world problems, like how do we model these sophisticated mechanical problems, and also I mean, I took a graduate course in it was called like I think it was biological mathematics and biology or something like that, and I ended up modeling the calcium fluxes, like the voltages through
Oh
the
yeah.
heart, through the cardiac muscle,
Yeah. Yeah.
and also I remember modeling insulin release in the beta cells in the pancreas. So
Mm.
so really kind of complex, fun stuff. And so I I I finished that up, and then I applied to dental school, and I got accepted to I think it was there's no dental school in Montana, so I got accepted to, I believe it was Tufts and Boston and
Mhm.
UOP and it was, I think Creighton, and
Nice.
yeah, so I ended up
Cleaned
going
up.
to
Yeah.
UOP. I
Okay.
figured,
Very nice.
yeah. So I wanted to move to San Francisco and be on the West Coast, and I thought it was, and so I went to dental school, and then
Nice.
when I was in dental school, Western schools are very pro kind of, like basically, hey, we're going to teach you everything you need to know. And when I was in dental school, I knew that there was more complexity involved with like full mouth rehabilitations and large like restorative like procedures. So I decided to work for 1 year after dental school back in Montana, and I encountered some cases that I knew were complex, and I didn't feel like I was as prepared as I wanted to be.
Yeah.
And so I decided to move on to PROS, and I applied to PROS programs and got accepted to Carolina and then Baylor. And so I decided to go to Baylor for my PROS.
Okay. Nice. Very nice. So yeah, I mean, it sounds like you kind of caught that bug, sort of on a whim, just like in physics lab, and
That's the way
you were
life
just sort
is.
of just drawn to the complexity of it. That's
Mhm.
fantastic. I actually I had a lot of interest in physics while I was in college. I was reading a whole bunch of like Carl Sagan and
Yeah.
astronomical stuff, and I found out pretty quickly you do have to be able to do math to do physics, and
Yes.
that was that was kind of the problem. That was what was in my way. Yeah, I stood no chance of being contributory to that field. But fortunately, I did have a mind for biology and things like that, and working with my hands, and physics kind of had a very roundabout way of dentistry had a roundabout way of finding me. But yeah, that's fantastic. So you went to pros residency at Baylor, and you've ended up in Bozeman. So kind of what was that journey out of pros residency into dentistry? Did you go directly into private practice, or what was that like?
Yeah, I worked. After my PROS residency, I just needed a job, so I worked in Dallas for like 2 or 3 years. I think about 3 years,
Okay.
and then
Yeah.
and then I was like, time to go. So I knew my compass always pointed back to. Um, I knew I wanted to go back to Southwest Montana, so
Okay.
it's always felt like home for me, and
Nice.
I just kind of packed up, and it was time for me to head on out. And so
Very
I
cool.
came out here and worked. I commuted and worked in a couple of private practices, and then when a space came available, I started my own practice.
Very good. Very good. So you're starting your own practice. It's a prosthodontic practice. I imagine you're doing full mouth rehabs. You're maybe doing some implants. I mean,
Mhm.
what was kind of like your mix right off the bat? What was really
Yeah,
what got you going?
I mean, at first, I think as anything, it takes a few years to really determine what you wanted. Who are you? What do I want to
Yeah,
do? And
you bet.
I think focus is uh, I think a key part of evolving as a clinician. I think you find what you really are interested in, and that's what you're
Yeah,
going to end up doing.
yeah, you gotta dive
Focusing on.
deep. Hmm.
And so
Absolutely.
so at first I did more general dentistry, and then now it's pretty much implant based.
Okay. So is there like a network of referring doctors or surgeons that are doing the cases, and then they're coming back to you
Yeah.
to get restored? Okay,
Yeah, it's
fantastic.
mostly I do tooth-borne, tooth-borne rehabs and some,
Okay,
it's a mix, but generally on the full arch side, I usually do about 2 cases to maybe 5 a month or so. It just depends on
okay.
the demand. There's not a lot of people in Montana, so it's
Yeah, sure. I understand. So I'm aware, of course, that you have a bone dental lab as well.
yeah.
So when did that come about? What was the impetus for starting your own lab?
I started my own lab just because, just like anything in life, if you want to truly master something, you really have to do the hard work and
Yeah,
dive deep. And so I started. I think I started my lab mainly out of just, in residency we make a lot. I mean, basically we do a lot of lab work is part of the
yeah, that's
requirement, and so
what I've heard.
I
Yeah,
somewhat missed that. And then also I was really excited about the transformation that the lab industry has gone through, and
for
so
sure.
I wanted to I really wanted to dive deep into that, and so I started the bone dental lab mainly for just my own curiosity, my own desire to control the I think really control the whole process for my patients, because
Right.
the understanding from A to Z is very important to minimize your risks.
Yeah. Yeah, no, I totally agree with that. I think one of the most transformative times in my own clinical practice, I do have like an all digital workflow for my full arch
Yeah,
now, and so the lab can do a lot of heavy lifting for me.
right.
But thankfully, there was a time before that for me where I did have an in house lab and a lab technician that would do all my conversions, and we had a week where I had 3 double arches. And his father was sick in Israel, and he
Right.
wanted to go back and spend some time with him. I was like, of course, you have to go do that. And so I had to do my own conversions for a week, and that's when I learned, how good and bad of a surgeon that I was,
Yeah.
because I figured out what needed to be done in order to simplify that conversion process. And by even just like the third conversion that I did that week, I was significantly better
Yes.
and giving my tech a lot better of a time when he came back to do my conversions. So I definitely learned that live, just starting with the end in mind and working your way backward.
That I think there's a lot of truth in what you said. Like the best surgeons that I know and work with really understand the prosthetic side, and
Yeah,
there's synergy back and forth.
for
And
sure.
I think that it's inherently a multidisciplinary treatment,
Yes.
and I think that's what's you you can't everybody has to be on the same page if you want to have the greatest amount of success and the minimal amount of risk, is
Hmm.
that everybody's kind of like mind melded together,
Yeah,
you know
for sure. Gotta be reading the same sheet of music.
yeah.
So with the lab, do you have technicians that are working in there as well?
Mhm.
Or are they serving like other practices, or is it all just, the work that you're doing in out of your clinic or?
Yeah, so we do have we do accept like digital, like clinicians that do have fully digital workflows. We
Okay.
will accept cases from them,
Okay.
and
Okay.
then we locally, we have in the past we've gone out and done records and do the whole, like basically do the whole thing.
Oh, cool.
Yeah,
Okay.
and
Okay.
so but Montana's a big state, and so driving 3 hours, it can
Yeah.
be challenging.
No, that's a lot to ask for
Yeah.
sure. Well, fortunately, everything's at the speed of the internet now,
Right.
especially if you're up to date on a fully digital workflow. So that's fantastic.
Mhm.
So, how has that kind of experience of building out the lab then kind of taught you more as, a prosthodontist? Like, what does that of a development really look like?
Yeah, it's honestly, it's very challenging. Like
Yeah,
like
I can't even imagine
yeah,
how you would
like
start that. Yeah.
manufacturing in general is a very challenging field. And
Hmm.
you know, my I think that I have a lot of sympathy and respect for laboratory technicians
Yeah.
and
I'm,
what they
I'm wearing a
do.
t-shirt right now.
That's right. Yeah, I mean they really are our partners,
They
and
are. Yeah.
and I think that is I think it's super critical to be to really defend each other and to be and work well together, because that's kind of what really makes the full circle.
Yeah. Yeah. Yeah.
So
I
we
agree.
can have a good outcome. And so it's I think, for me, because I do all the CAD designs and stuff for my patients, I tend to
Great.
get a little lazy with communication with the lab, but I can't underemphasize how critical that is, as far as like how your relationships are with your other with the people you work with. Like, how well do you communicate with them, and how clear is your from the clinical perspective, how
Hmm.
clearly can you describe what you intend the outcome to be? Because the more information you can communicate with the people that are fabricating these things, the better, I think. Like I tell my patients, I don't want any surprises, and so
Right.
why we kind of go through a lot of uh, that. Why I'm very systematic about things.
Yeah, that makes sense. And I think, a lot of times there's a bit of a void in knowledge when a dentist is looking for different labs to go to. Let's say you're looking for a digital lab to do your designs and mill out your zirconias. You'll ask questions about what the lab wants, right? Like what kind of records were they looking for?
Mhm.
What are the different stages they work with and things like that. But there's a lot of questions I think dentists don't know to ask. Right,
Yeah,
in terms of like how they actually make their prosthetics, different, and not even just turnaround times, but just like what is their quality control like? How many designers do they have on the team? How experienced are they? What, how is everything? What do the different departments look like, and how is all that flow? And I'm curious about, with you having such a direct relationship with your lab and them making that final product from start to finish, has that kind of taught you some things that dentists might need to be a little bit more discerning about when they're looking at different labs?
yeah. I one is on your end.
Hmm.
I think on the clinician's end, we absolutely need to have very consistent and standardized record taking.
Hmm.
And
Hmm.
I think that's been the most powerful thing that has changed just my own practice. Like, I kind of like came out of the womb, out of a pros residency, right? Knowing kind
Yeah.
of like just having that beaten into my head as far as
Right.
how take records and
Yeah.
things. And I think that standardization and record taking is massive.
Yeah.
As far as like reducing the entropy or chaos that's in all the information that the laboratories receive. And
Yeah.
so I think that so one is portraits or face scans,
Hmm.
and then the other one is shades, standard shade selection with photos, and then some sort of jaw relationship record, treatment position. And
Yeah.
so on the clinician side, their responsibility is to determine the treatment position, and then also be able to provide enough data so that the technician can reproduce the patient in their like in front of the screen. And that's the goal, and that's what I do with all my patients. So that's helped me on the clinical side. And then on the laboratory side, on the manufacturing side, they have to absolutely understand their materials. Uh, on the CAD design part, it's a little chaos out there. We'll probably get into that.
Yeah. Oh
Um,
yeah. Let's do it.
right, and on the manufacturing, like tool changes, things like that, like all the little details to keep your systems like machining, like what kind of validation and verification are you doing for your machining?
Yeah. Yeah. So I have two. context that kind of, they don't educate me about those things, but they make me vaguely aware of them and humble me a little bit. So
Sure.
my dad comes from aerospace engineering. So
Yeah.
he had a manufacturing company. He made parts for Boeing, Gulfstream, and that was like my summer job. I was working a CNC machine and learning about, quality control and tolerances and, the human error that can be involved in those manufacturing processes. And then on top of that, before I got into dental school, part of the things that I was doing to build out my resume was working at a dental lab. So I worked in
Yeah.
the CAD/CAM department for a lab. And the number one thing that got drilled into me before I ever learned how to do any type of dentistry was shit in, shit out,
Yeah.
right? Like if the record's bad, the product's going to be bad. And, dentists had this idea that somehow, given it's almost like that scene in the really cliche scene in movies where they zoom into a very, poorly resolved image and then they resolve it more and somehow it's higher quality
Right.
after they zoom in. Dentists think that labs can do that.
Yeah, I know.
Right?
Yeah, it's with
Yeah.
the Bourne or like the satellite
Yeah.
images. Yeah. That's not how data
Exactly.
works.
Yeah, exactly. So somehow it's not it's
Enhanced.
no longer, we're just trying to minimize the loss of accuracy, but
Right.
somehow we're supposed to create it. But those have really gotten me a better appreciation for what it takes to have high quality records and result in a high quality product. And generally as hard as a lab's job is, it's a lot easier when that data is accurate and when it's good, and it makes the doctor feel a lot better when things work well. But that's only if they did the records correctly. You
Right.
can't create accuracy. So, but yeah, no, that's really good. So you've got obviously your prosthodontic practice, you got the dental lab, and then I also learned a little bit about what you're doing with your smart mouth technologies company. So can you tell us a little bit about that?
Yeah. So I started I just kind of, I think just having my background and like a technical background and then also having a clinical background, I think
Mm-hmm.
I'm particularly good at kind of teasing out like some fundamental problems that
Mm-hmm.
where I think we need improvement. And so I started a engineering, I guess would be a tech company really.
Yeah.
And I have about 5 engineers on staff, and we essentially we have a bunch of projects that we're working on, and so the I think one of the biggest first projects that we're working on is a web application called Will It Break, and that's a finite element analysis for dental prosthetics.
Mm-hmm.
And essentially, what it does is it tests designs. What we want to know, and I think what is really important for designers to know is are their designs set up for failure from the beginning? And so the we have a bunch of rules of thumb, right? Cathedrals were built on rules of thumb, but structural engineers don't use rules of thumb anymore to build skyscrapers and buildings and
Right.
that kind of stuff. So we use basically our goal is to increase the engineering rigor into this space and make
Okay.
it more sophisticated.
Okay. Yeah. So can you just fundamentally, can you tell us what finite element analysis is, how it works, and exactly what it tells us?
Yeah. So the interpretation. So what finite element analysis is it's basically a numerical It's a numerical computational method for solving incredibly complex equations. And these, when you take a structure or like let's say a full arch,
Mm-hmm.
and and let's say a patient bites on it, or let's say they grab some beef jerky and bites down right on
Yeah.
that distal cantilever,
Mm-hmm.
right? So what happens is a very complex tensor field is created in that structure, in that full arch, and what it does is that field describes how that force is experienced, I guess, by this prosthesis. And so finite element analysis is a numerical method of breaking that full arch into tiny little chunks.
Mm-hmm.
And what the reason why that finite element method works is because computers are very, very good at basic summing up a bunch of little solutions together. And essentially what it does, the output is stress. So it calculates this very complex tensor field that is created, and strain in the prosthesis. So the interpretation of that, and you can also tack on a failure theory. So there's theories about a material has, ultimate tensile strength and things like that. We could describe those little teeny elements and sum them up, and we can apply a failure theory to it. And the output is essentially, here's where usually the output is in a heat map. And the heat, if you've ever seen this before, you'll see it in some of the dental literature too. The heat map tells you where the stresses are, and then depending on the material, you can somewhat figure out where it's likely to fail.
Okay.
Yeah.
So something I'm curious about, and I don't mean to break your stride on explaining what all this can do.
No.
So I saw, in your presentation, you had several different designs. There was actually a really cool part of your presentation was just like an A and B of like which one is going to break, and it's just kind of everyone's just being intuitive about it. You're not seeing a heat map or anything, and it was very counterintuitive. And you kind of talked about the multifactorial processes and stuff like that. But back to my question. So something I'm very curious about, and I hear this talked about without a whole lot of really substantial argument. It's just kind of, it's hand waving for the most part. So, something we've seen in the past several years is the proliferation of direct to multi-unit design as opposed to using tie bases in these restorations. Through finite element analysis, have you been able to make any conclusions about stress points between those different systems and what's kind of better set up for success long term?
No, I wouldn't say I have definitive evidence on one or the other. I do. I can tell you that there is. So theoretically, when you're designing any kind of complex mechanical system, you want to simplify as much as you can, and I think that when I don't think there's enough evidence to show which one is best. However, there's a phenomenon called tolerance stacking. So when you add a lot of things together and you're trying to get them all to fit together, you
compounding inaccuracy.
Yeah, you compound your error. And so I think theoretically, direct to MUA is doable. I think there's some fundamental problems with that as well. But I think both are doable, and I don't believe I can answer that question yet.
Yeah, fair enough.
Yeah.
I appreciate you not having an answer because most people like to have some time of answer.
No, yeah. No, I think we should, and that goes on. Yeah, I mean, I think we should have real actual evidence to.
Yeah. I mean, the thing that I've noticed, anecdotally is there is some issues with the structural integrity of the I've heard them referred to as chimneys. I don't know if we have a prosthodontic term for them yet, but the fluted end that actually screws down into the multi-unit, if you have a very long, flute, of this thin zirconia material, I have definitely seen that chip.
Yeah. Oh yeah. That's set up for
that. Yeah, for sure.
I mean, this goes down to like who's doing the designing, and that's why WIB exists, is basically, the who's doing the designing is you're not having an engineer. There's not a mechanical engineer designing your designs. It's somebody, it's typically, somebody with like a high school diploma or something like that. It doesn't necessarily mean that they don't know anything about, mechanics, but the odds are they don't.
Yeah.
Right. And so I think it's, on that side of things, on the design side, there's a lot more emphasis on, does it look like teeth? And that's important, but at the same time, it's got to work, it's got to be structurally sound. And so I think there's this pendulum is going to swing, I think, back towards more like we absolutely know like fractures and prosthetic complications are extremely inefficient part of in
Hmm.
our industry. Like right now, prosthetic complications and stuff are a huge inefficiency that needs to be
Yeah.
addressed.
For sure. So, I'm curious, do you think that this is probably a difficult statement to really make, but, when it comes down to, what is making a prosthesis vulnerable, is it more so going to be, a design aspect or some aspect of how that's been configured, or is it going to be more on the fabrication side of things, how well a lab handles zirconia and centers it,
Yeah,
so on and so forth?
I think I hate to say this, but it's a combination.
It's got to be both. Yeah.
It's multiple variables like come into this
Okay.
equation, and so I think there's not one silver bullet here
Yeah.
that's going to solve all the problems.
Sure.
But
Sure.
I think we kind of, I know that on the design side, we're very focused on getting a very nice valid tool for designers to use to help them design better,
Hmm.
as far as improving the structural predictability of their prostheses, and I think on the manufacturing side, there's other things that need to be done as well.
Okay. Okay. Fair
Yeah.
enough. And with the will it break application, so as far as I remember, when I saw the different heat maps and stuff, it looked like they were mostly being mapped onto monolithic designs.
Yeah.
Are you able to do analysis for a system that has a substructure, let's say a titanium
Yeah,
substructure?
so we're actively working
Okay.
on assemblies essentially, and
Okay.
so that
Okay.
would be the term is basically a complex assembly, and then analyzing those. That is much more challenging to code for. Uh,
Yeah, I would imagine.
yeah, and
Yeah.
we have to account for cement and things like that.
Right.
It's a pretty complex problem. I'm really curious about what we're going to find. Like
Yeah. No. I mean,
I'm really interested in
yeah.
how, in what we're going to see from the design side, and uh, we're also embarking on mechanical testing as well for
Hmm.
validation, like model
Yeah,
validation.
I think that's great because there's just so many different design and fabrication options out there, and we all kind of have these vague ideas of what can work in different situations and what you should do, but it's very difficult for us to really quantify those things.
Yeah,
Um,
yeah, and
go ahead, please.
well, that's the goal, is to get away
Yeah,
from opinions, and
right.
get away from opinions and have really quantifiable,
Yeah.
objective data that we can get. That's the future. That's what's going to happen,
Hmm.
and so I think we're going to see less polarization as we get more data.
Yeah.
And so
Yeah.
so we're kind of we're in more of a speculation kind of landscape right now,
Yeah.
because we just don't have the tools. We don't, and I think that's the key. The goal is to get as far away from that as we can. I
Yeah.
mean, to move things forward, we need the right tools, and we need
Right.
good data.
Yeah, yeah. I mean, I think so much of it is purely anecdotal because
Right.
if you ask me, what's going to be the best restorative material for any given case, the safest thing to say is, oh, it's multifactorial, right? But
Yeah.
really the answer that people will have is entirely dependent on who they've been talking to,
Yeah.
their own experience and who they've been talking to. But both of those things are inherently biased, right? Some people just swear by monolithic zirconia. It's God's gift to Earth. It's fantastic.
Right.
Other people will tell you the modulus of elasticity is way off, and you get saucer defects around implants and all these things. Some people will say you have to have a titanium substructure. Other people say, oh, well, then the superstructure is going to be thinner and more prone to fracture or something.
Yeah.
We're all just kind of shooting in the dark. So I'm very interested to see what comes up from that.
Yeah, yeah, me too. And this kind of also, I think this also kind of can go into another. I think thing that's going to impact dentistry significantly too is a lot of our studies and our observational studies, and
Hmm.
I think that I think we need to move into more patient specific data.
Yeah.
I think we need more resolution on that patient that's sitting in the chair before while we're making these decisions about, okay, how am I going to design this prosthesis, and how and what, as far as the implant, the surgical plan and things like that. But I think like bite force, just one. I mean, a little
Huge.
old lady. I think I said this in my talk, like
Hmm.
a big massive cantilever totally broke any kind of rule of thumb. But
Hmm.
that one is going to do fine because it's
Yeah.
in a different environment. We're all
Right.
different. And
Yeah.
so, a middle-aged male that bruxes is going to be entirely different than a little old lady that's eating mush all day.
Yeah.
I mean, it's
No.
just totally different environment. And so we really need to step away from these. We kind of need to evolve past, like get through this period of and throw down our rules of thumb and start
Hmm.
using more sophisticated tools to make these decisions.
Yeah, I totally agree with that. And I think that, rules of thumb can be very useful
Yeah,
because they are able to assume all of the uh, complexity and the different dynamics that go into these systems as equal, right, across all patients.
right.
And that's great, but still that's not really enough to inform every decision you make for each patient.
No.
Something that I really enjoyed from Dr. Sonata, who went and, of course, he was talking about his FP1 cases and had
Mhm.
some beautiful documentation and everything. But one of the things that really, I left with was he was just talking about the FMA angle and how
Yeah,
he assessed his cases. And, I was aware of that, but, he was like, I can look at a patient and I can tell how big of a problem they're really going to be for me from an occlusal standpoint
right.
in terms of bite
I,
forces, just off of that
Yeah,
anecdote that he
every
gave me.
prosthodontist is just that they have that burned in their brain.
That's the one.
Yeah, it's yeah.
Yeah.
Going through a pros residency is basically like, I mean, you just show up and it just gets hammered into your head eventually, and eventually you
Yeah.
learn. But FMA it really is it is a useful uh,
Hmm.
a tool or a diagnostic aid,
Right.
and a treatment planning aid. The But again, it is just an aid, right? It's
Of course.
I
Yeah.
and I think that I think that we're even going to get better, like
Hmm.
you know what I mean, with more data, like as far
Yeah.
as like, hey, bite force, things like that.
Yeah, yeah. Well, I think as we get more, technology and metroscopy to check out what occlusal forces look like in a given system, right? With like the T scan, looking at
Mhm.
where someone is. I mean, even just knowing how they chew is a really important thing, right?
Yeah,
Like if you might be concerned about some structural integrity issue on the left side, but they never even chew over there, right? So like just knowing how they function is extremely important. We don't even really measure for that.
no, like the envelope of function, like
Of course.
where they're actually spending most of their time, and
Yeah.
and then we have, and then more resolution on like what's the parafunctional possibilities, and then how
Hmm.
much load could that be.
Yeah, yeah, and two, we talk about there's an issue with making a patient fit a prosthesis,
Yeah,
right? And we have these rules of thumb about how much space we need for a given material, and why do we think that we have to get to 15 or 18 millimeters of prosthetic space for every single patient? Do you really need to do that, right? We're not necessarily making an informed decision. We're just going off again that rule of thumb, and that's affecting how the patient is being treated. It's affecting what you're doing as a surgeon.
yeah.
So that's kind of an uninformed decision. So yeah, I think we stand to gain, a lot of advancement in terms of, how we take care of people and what we're able to do.
Yeah, and I think this kind of segues into a concept of every clinician like forms a model in their head, as far as
Yeah.
like we have like a biomechanical bucket, a
Uh-huh.
biomechanical
Yeah.
model. We have an
Right.
aesthetics and phonetics model. We
Hmm.
have like a physiology or a kind of a pathology model. Um, and a medical model about how this patient is going to, what should I do? So we start filling in inputs in all those buckets, and we start figuring out, okay, given all this input, what should I do? How am I going to treat this patient? And then what's the outcome going to be? And I think it's really important. I think to get to mastery, I think it's really critical to make those models, one, very diverse, like complex. So you have lots of inputs and you're analyzing lots of different data points. And then I think it's also really critical is to harvest as much experience or much knowledge as you can from your experience points. So every case is an opportunity to enhance those internal models. And so I think the clinicians that reach mastery, I'm not saying I'm a master by any means, but I think all of us are, or most of us should be on that path. Like, how do I really get, good at this? And I think that's the kind of the pathway, because, experience, you can kind of rinse and repeat, kind of robotically, right? And I think your job as a clinician is to really grow in your sophistication as rapidly as you can.
Right.
You know?
Right. No, I totally agree with that. And I think that, a lot of times, the feedbacks that we're looking at are not always something that really lends to that kind of mastery that you're talking about. Like
Yeah.
a lot of dentists, they take all those different models that you just mentioned and they form a certain formula for their practice. And they, like you said, rinse and repeat day in, day out. And sometimes as long as the office is doing well,
Right.
you get this idea that like you're doing something right and you're doing it the best, and other people should be doing it that way too. And, you're not necessarily committing yourself to excellence that way, because you're looking at different surrogate markers that aren't necessarily, tied to, what is the end product? What have you provided for the patient? What's really going to be the best long-term? And, one thing about full arch is, we are measuring our success on kind of a monthly basis, right? It's just how much did the office do? How many arches did you do? Not, did the thing that you did today, is that going to last the patient 25 years? And we have no idea.
Yeah.
But if we had some data, we could have a better idea.
Yeah.
Right.
Yeah. And a happy patient isn't necessarily the best metric.
If it's screwed in, they're probably happy.
Right.
And that's not enough.
Yeah. So I mean, you should look at your input. What was my outcome? And did I achieve my goals? And I think that's like I think that's so important to get to a place where we all want to be,
Yeah,
and it's
sure.
easy to kind of rinse and repeat. The patient's happy, I must have did a great job. But
no issues.
Right. And
Right.
but it's because when you have that like mentality, as far as like, I'm really going to analyze all of my outputs or all my outcomes, then when you get into a tough one, that's what's going to save you.
Yeah. Right. So, yeah. No, that makes a lot of sense.
Yeah, because they're not all easy. It's like if you look at rebuilding a mouth, it's incredibly complex, and we have great technology. Like photogrammetry has been a game changer. There's no question about that. And it's in a lot of intraoral scanners have been very useful, and but I do think that they are, but inherently it's very complicated, and so sometimes we get bit. Sometimes it doesn't work so well.